From 2nd MBBS from Osmania Medical College. Today we are presenting a case of an infant with a rare abdominal swelling. So the infant presented with a large swelling on his anterior abdominal wall, as you see. And the history of presenting complaint is that there was no pain associated with the swelling and no GIT symptoms. He had no history of vomiting or diarrhea. And then moving on to general examination, all the vitals were normal, and the pediatric history, his antenatal, natal and postnatal periods were uneventful, and he attained the milestones appropriate for his age. Moving on to the systemic examination, on inspection, a large mass extending from the xiphi sternum to the umbilicus was found, and the skin over the swelling was normal without any pulsations or peristalsis. A tuft of hair was seen on one end of the swelling. And on palpation, it wasn't tender on palpation, and the consistency was, it was variable. Some areas were hard to firm and some areas were soft, and the edges were rounded and even, and the skin was pinchable over the swelling. And on percussion, it was dull to percuss. So the other systems were all normal, and the baby was sent for routine laboratory investigations. All his CBP was normal, renal function tests and liver function tests were normal. So he was sent for radiological imaging. So on radiological imaging, first ultrasound was done. So 9.8 cross 7.6 centimeters multicystic mass with loculi containing internal echoes or debris was seen, containing a part of the liver. So after the clinical examination, the impression was that it could be an umbilical hernia or a teratoma. So after ultrasound, they thought it was a teratoma and was advised for CCT abdomen. Next slide. So there was evidence of a thick wall multicystic lesion with fat and calcification noted in the midline with exophytic component. The left lobe of the liver was herniating into the mass, and the rest of the liver was normal, and there was a defect in the anterior abdominal wall. So the impression was multicystic calcified lesion. So he was advised surgery. These are the images, and laparotomy was done. The whole mass is removed from the liver, and the defect in the anterior abdominal wall was closed. So after the mass was removed, we could see some rudimentary facial structures on the mass and a rudimentary heart. You can see the nasolabial folds which are developing, and the pinna. So it was sent for histopathological examination and staining. So this is the gross and cut section. You can see the coelomic cavity and the subcutaneous fat, and there were some areas of calcification which are evidence of bony structures. So you can see these slides, there's a fetal liver with a branch of the portal vein and hepatic sinusoids. That's the intestine with the crypts and mucosa and submucosa. That's the rudimentary heart with the rudimentary atria and ventricles and the arch of aorta. So on microscopy, multiple sections studied from the fetus show structure of skin, subcutaneous tissue, liver, intestine, and multiple foci of necrosis and calcification. So the final diagnosis that it is a ill-formed fetus of 16 to 18 weeks gestational age, and so this is called parasitic twinning. It's a very rare phenomenon, occurs only in 1 million live births, and there are only a handful of cases reported in India and abroad. So this is one of the cases in India, one of the very few actually. This is the second case. And management is surgical excision. So the prognosis is very good because there was no vascular or bony continuation with the parasite, and there was no bowel continuation, and they didn't share any vital organs like the brain or the heart. So the prognosis is very good, and he can lead a normal life. These are some other cases. That is a thoracopagus, and that's another parasitic twin. This is a vena vani, we all know. And actually, parasitic twin is a variant of conjoined twins. I put that slide. And this is the post-operative photograph. And the child, you can see the child is normal. Thank you. Even parasitic.
Obviously, this monozygotic, right?
Audience. What?
You have craniopagus, thoracopagus, fetus in situ, omphalophagus, Iliopagus, and a cardiac twin. Why are you making me surgery?
Be louder. It could have been an umbilical hernia with a giant nevus.
Why was it suspected as umbilical hernia? That is a very good question from that girl. It was in the epigastric region, but it was suspected to be umbilical hernia. Why?
First impression was it can be an.
Was it reducible?
No, it wasn't reducible.
Okay.
After that was the first impression. That's a difference.
Leave this case.
Umbilical hernia is common in the.
Leave this case aside. Can anything be a possibility in that area, which is a commonly we will see? Have you heard a term like divarication of recti?
Yeah, duplication of the intestine.
So some form of epigastric hernia can be, instead of umbilical hernia, it could be epigastric hernia.
Thank you. For conjoined twins, for
Craniofagus, it has been done.
It has been done, but then not successful. What? Where? In Syria.
No, the first one was done in Maryland.
Not yet done for them.
That's in Maryland.
2 cases were done in Singapore, but
it's been done in Maryland.
Pardon?
Maryland, sir, in USA.
Okay. This case is unoperable. I mean, this Nethagani case is unoperable.
Thank you. It was a very interesting case. మీకు అర్థమవుతుందా ఇదేదో సేఫ్ మోడ్లో